All right, I think I see Jen is dialing in right now. So I'm going to go ahead and welcome everyone to this workshop. Thank you very much for attending. And we're very excited to have you. I hope that you were all very excited about this track after Marilyn Nolt gave her keynote speech last night. If you weren't able to see it, I really recommend that you watch the video recording of it once it becomes available. So I thought that we could go around and just make a first set of introductions. So I'll just go ahead and start. My name is Shamal Patel, and I am a member of the Digital Medicine Society. I'm also the clinical research head for the Pfizer Innovation Research Laboratory, which is a lab based in Cambridge, Massachusetts, looking at digital medicine implementation into clinical trials. I'm also a board certified neurologist and neurointensivist practicing at Tufts Medical Center here in Boston. I do want to add my disclosure here at this time then that all the things that we're going to talk about during this workshop are representative of my individual views, don't necessarily represent the views of any of the organizations I just mentioned that I'm a part of. And so I'll let Brad introduce himself next.
Hi, everybody. It's amazing to see everybody here and to know that there's such interest in this topic. I am a research faculty at the Hinda and Arthur Marcus Institute for Aging Research, which is part of Hebrew Senior Life and Harvard Medical School. And there I am the director of the Center for Research on Mobility and Falls in Older Adults. And I too have no disclosures to report.
And Shamal, I believe you're also on the call. Would you like to introduce yourself?
Yeah. Hi, my name is Shamal Patel. I work with Shamal at Pfizer in the Digital Medicine and Translational Imaging Group. I lead a data science team where we focus on developing algorithms to extract clinically meaningful measures of health from data collected using wearable devices. And I have the same, disclosures as Shamal. The views I present here are my own, and I'm super excited to join you guys in this hackathon and help you as a mentor.
Great. And Jen, do you want to introduce yourself?
Of course. Hello, everyone. Really great to be here. My name's Jen Goldsack, Executive Director of the Digital Medicine Society, or DiMe. No disclosures. The views will be my own, but what we always try and do here at DiMe is sort of bring a sort of big tent community approach to the field. So oftentimes, as members of DiMe are sort of remarking on the field and providing sort of insights and advice, hopefully they're not just drawing on their own expertise, but on knowledge that they've gained from a very sort of diverse, whether that's regions, whether that's backgrounds, whether that's disciplinary, a really diverse sort of and large sort of thriving cohort of folks devoted to advancing digital. So really happy to be here, and Jume, back to you.
Great. Actually, I'm going to just give you a description that we're going to have, Brad is going to give a talk, and then I'm going to follow that up with a couple more remarks. And then we wanted to open it up to you guys to see if you had any questions for us. And I believe that we do have a little bit of time. If you guys do want to stay, I'm available a little past 2 as well, if we go over. So with that, I will turn it over to Brad.
Okay, everybody can see this, hear me? Good. So feel free to just unmute and interrupt if you want to do so during my talk. And what I wanted to do is just, obviously we are all here today because there is great promise in remote assessments and digital health around gait and physical activity monitoring. And there's also a whole kind of unique set of problems that go along with it, especially when we are thinking about older adults. So I hope I can provide some initial context for the promise and the problems, and then we can kind of take it from there. The first thing I wanted to highlight is that when we think about gait or balance or physical activity, is that it's really controlled by a very complex system. So whether we're standing still or walking down the hallway, millions of receptors are providing information to our central nervous system about the environment and about our body within the environment. Some of that information is used to kind of control reflex arcs, but also some of that information is sent to the central nervous system in the brain, where it's integrated across all different forms. It's modulated and ultimately utilized to coordinate, plan, and execute motor programs by way of motor signals sent to hundreds of muscles. Just make sure. Okay. And as that motor program is executed, it causes the body to change and therefore the sensory input to change. And this very complex system is dynamic and changing throughout our lives. The reason that it's complex, and we need this complexity, because we never just stand or walk down a hallway kind of all by itself, right? We have to be able to walk through very complex and ever-changing environments. And we have to walk through complex, ever-changing environments while performing additional tasks. So for example, we have to walk while talking, and we have to walk while carrying things, for example. This ability to dual task while moving through our environment is really central to our daily life, our ability to maintain our independence. And therefore, measuring the quantity and quality of gait and physical activity really provide an amazing opportunity to provide insights into health of not only the physical system, our senses and our muscles, but also into the integrated function of our neuromuscular system and our cardiorespiratory system. And as a result, in-person assessments are really foundational to both research and clinical care. And these assessments can range anywhere from measuring gait speed with a stopwatch, so to measure how far or how fast somebody is walking over a certain distance, to very complex measurements of gait and balance using motion capture. And in my mind, really the challenge to this is that these are great. They do provide insights into our health, but when we assess things in the clinic, they're really only one snapshot in time and don't really reflect the dynamic changes and situations that we are in real life. And as a result, I think this is where the promise comes in, right? Digital technologies and connected technologies can very easily capture human movement, and it can do so with high frequency, and it can do so during our habitual physical activity, and really during the activities that a physician and healthcare professionals are interested in helping people to maintain. But at the same time, I think widespread adoption into clinical practice of these digital technologies is not going to be easy. So what I wanted to do is really highlight 5 different challenges in my mind, and I'm actually just focusing on digital technologies, specifically on the capture, motion movement capture side of things. So I think in order for things to kind of be adopted, digital technologies to capture movement really must provide context. So first of all, what I mean by provide context, if we have a movement, that movement, we can easily capture that movement. We have to remember that that movement is stemming from not only the individual performing the movement, but also the task and also the environment in which the task is being done. And really, I think the important thing here is that in a clinical setting or in a research setting, the task and the environment are very much controlled. And so if we see a change in movement, that's really suggesting that the individual has changed. When we are thinking about remote assessments, we no longer have control of the task or the environment. So that adds a huge and I think very exciting layer of complexity. And actually probably a lot of opportunity, if done correctly, to learn a lot more about the individual. So for example, if we are remotely monitoring physical activity and we see changes in, let's say, step counts, how do we know that those changes are due to a change in health or perhaps a change in the weather? kind of similarly, if we see a change in movement, that might not really tell us too much. But we know, for example, as I mentioned in the first few slides, that the ability to dual task, to walk and do additional tasks at the same time, is very important and actually indicative of cognitive status and brain health. So it might be that while movements don't necessarily change, the context in which those movements are being performed may change. Second, I think digital technologies to capture movement really must go beyond step counts or even gait speed. We know that daily step counts as measured by a Fitbit or an Apple Watch or gait speed measured in the laboratory are really highly sensitive to a change in health status, but really that's it, right? Because these are such integrated outcomes, they reflect very sensitively a change in health status, but what the underlying cause of that change is very difficult to discern just from those kind of average metrics. And just as a quick example, let's see here. So the 6-minute walk test is commonly done. It just records and measures how far a person can walk in 6 minutes. And here are examples from 2 different patients that we had in a study where we put sensors on the bottom of their shoes to measure their strides. So on the x-axis is the stride number. You can see each person took about the same, maybe 160 steps during the trial. On the y-axis is the stride time, so the time between consecutive heel strikes. So you can see this first person, the first stride took about 1.1 seconds, the next stride took a little bit less, and so on. You can see that if we were to just look at the average stride time during these 6-minute walks, they're quite similar. If we look at the stride time variability, they're quite different. So if we would have stopped at just looking at the average stride time, or maybe even the distance walk, it captured a little bit, but not everything about the quality of the movement. And it turns out that on the left was an 80-year-old who was cognitively intact with no overt disease. On the right was a 74-year-old with mild dementia. And it turns out that subtle changes in stride time variability are actually quite predictive of dementia and the risk of developing dementia in the future. So I think when we think about digital technologies and remote assessments, if we can go beyond traditional kind of step counts or average measures, that can really provide a lot of additional information. The next really big area is we need to consider the user, especially when we're thinking about older adults. So obviously wearables are ubiquitous, they're everywhere. There will be even more of them in the coming days and months and years. They present with challenges. Certainly there are benefits, but there are also challenges. For example, are they easy to put on and take off if somebody has arthritis? Are they waterproof? Are they fashionable? As an example, we are working right now with a company who has developed a belt that people can wear to record movement, identify if somebody is experiencing a fall, and deploy an airbag by the time the person would hit the ground, which is amazing. But it actually looks a little bit like a fanny pack, and therefore many people do not want to wear them, especially outside of their homes. So people's kind of acceptance and sense of fashion and worry about what other people might think is real, and it oftentimes trumps health. So I think that's really important to note. It's very hard to keep things charged in the field. We also, for example, you might not even think of it, but in research especially, we need to know if the device is actually being worn by the correct individual. And all of these things are really hard to keep track of and to ensure. And it becomes even more complicated when we're talking about older adults, especially those with cognitive impairment. So you might think then, well, let's not use wearables, but let's use contactless sensors. And at the same time, these are amazing, but they also present with challenges. For example, it's great. We can measure somebody's physical activity within the home by putting a sensor in the, maybe in the corner of the room. But that only is going to provide information about activity outside of the home. I'm sorry, inside of the home. So we don't know anything about then activity outside the home. Oftentimes, especially older adults are wary of invasions of privacy. And then there's a big challenge of what if there are two people in the room at the same time? How do we keep track of who is who? Next, I think it's really important to ensure accessibility. I won't touch on this too much, except to say that it's really important. I think if we're not careful, implementation of these connected technologies within clinical research, especially within the research setting, I think might lead to bias in participation, and therefore bias in results, and therefore bias in conclusions, such that conclusions don't necessarily then generalize to all older adults, and especially diverse and underrepresented populations. And then even if we have validity and we want to incorporate something into the clinical setting, we need to ensure that all patients can benefit from technologies. So for example, we are working with a housing setting that is subsidized housing. And in that setting, not all individuals have Wi-Fi within their rooms. And then finally, I think we need to figure out a way to guarantee accuracy. That's kind of been an overriding theme, but I think it's really critical, both for investigators and physicians. We really need to be confident that the data that we are seeing is accurate and reliable. And to that end, I think these days it's so easy to capture lots of data. And it's really easy actually to develop an algorithm to give us some outcome. So for example, if we have an IMU that measures accelerations, we can develop an algorithm to give us step counts. But this black box is kind of scary, right? So it doesn't really care if the person was actually wearing a pendant or a wearable, or if the patient's dog was wearing it. It's still going to give us measures of step counts. And I think then to that end, we really need to think about kind of this black box and making it a little bit more transparent so that we can really understand and ensure that the measures that we are capturing and trying to make clinical decisions or inferred conclusions based on research is accurate. So I think these are all issues that we really need to think about as we develop our digital technologies. And I've really only focused to this point on capturing data in the field. And there are a whole host of additional challenges. And I think my final message is that because of these challenges, I'm often wonder if there's one size that fits all, or if we need to really focus in and think about specific healthcare issues and problems and develop strategies specifically for those problems. So with that, I will stop and say thank you and happy to talk more. And best of luck.
Thanks so much, Brad. So I'm going to just follow up on a few of those points, as well as make a couple of other remarks on this track specifically, and then give you guys an opportunity to ask questions afterwards. So I think building upon what Brad has just said, we really want to think about, have you guys think about the context of use for these kind of three problems that we've kind of presented to you regarding the traditional clinical encounter, the clinical research applicability of these clinical measures, and then also just the health and general health monitoring that people in the population, both people as well as patients with certain conditions, are looking for when it comes to monitoring their own health given that all these emerging technologies have become available. So I think as a starting point, I wanted to kind of bring up a couple of things that Marilyn Nolt, our keynote speaker from last night, had discussed, and that she wanted actually me to kind of highlight again during this workshop as very important. And I think that one of the quotes that I had thought about was something that Steve Jobs had said back in the 90s about starting with the customer experience and working backwards from that instead of starting with the technology. And he specifically said it starts with what incredible benefits can we give to the customer, and not starting with what awesome technology we have. So I think that really highlights the need to think about the audience, as Brad was just saying. Who is it that we're targeting this for? One solution may not fit. You may want to consider different types of interfaces that are available for different people with different backgrounds. One of the examples I have of this is something that some of you may be familiar with. It's called a NeuroPace device. It's actually an implanted seizure device that's implanted by neurosurgeons into the brain that target areas of a patient that may be epileptogenic. That's maybe found on imaging as well as previous more invasive monitoring. And this device can actually be implanted and acts as a as a treatment device to try to detect when kind of potentials are forming in the brain that indicate that a patient may be having seizures. And it's actually programmable to the point where the epileptologist can take a signal from this device, look at that signal and tell the machine that this is the signal from this patient that I want you to identify and treat if this patient has these signals. There's also a way of targeting it where you let the machine kind of decide what kind of rhythms may be abnormal based on its preset patterns. So it's very customizable. And then on the other end, the patient has an application that has an interface that allows the patient to see and interact with the device. And so these kind of three users, the surgeon, the neurologist, and then the patient, all have kind of different ways that they interact with this technology, all to treat their underlying seizure condition. So I think that's a great example of, one size may not fit all, but one technology could provide that solution using different interfaces based on who they're tailoring that interface to. And in terms of bringing it back to the complexities of both the clinical practice as well as patients who are participating either in their kind of routine standard of care when they meet with their doctor, or if they're going to participate in a clinical trial, I wanted to share this slide that Marilyn had sent me. If you give me 1 second to share my screen. So this comes from a group actually at the Brigham and Women's Hospital, as well as Harvard, which is called the Multi-Regional Clinical Trials. And I've sent this link to the MIT organizers, and they'll make this available, the entire deck, for you to look at. But I wanted to highlight this clear communication aspect, both for our clinical trials, but also in our clinical encounters as well, that there is a very high degree of patients and people in this country who do need help and are not necessarily proficient in the language that we would use, in our kind of maybe our technical and scientific or medical communication. And, this kind of low health literacy really can affect how they feel in terms of being able to access these services and information for their disease conditions, their access to clinical research. It may make it intimidating for them to join into a clinical trial, and it may make them reluctant to join into a clinical trial unless you make that trial, the instructions, the material, how you teach people how to do the trial can be very important. And Marilyn did share last night too that when she participated in a clinical trial with a research nurse, and they taught her how to recognize her kind of what we call off times with her Parkinson's disease, that it was very, kind of set off a light in her head saying, oh, I have cyclical symptoms that I had never really considered before. And so that's, a good opportunity for people to get more education about their disease as well. And this allows them to, make healthcare related decisions that are informed. It allows them to, potentially have better health outcomes as well, since they're able to get access to, to treatments and to understand their condition. And so I think we wanted to highlight this when you think about the end user and, when you make your pitches, how is this going to be accessible? Really at the heart of it, it's patient-centric. We have Marilyn is actually the judge for our tract, in this way, because she's, I think, one of the more qualified members to really say this is something that patients like myself will have to interface with and will use and make sure it's accessible. She mentioned the example of, with her dyskinesias, as you could see during her talk, holding an iPhone is challenging. Being able to target a button on a screen is difficult for a patient with her movement disorders. And so, a solution that works for a Parkinson's patient, as she said, may be something more of a wearable that's easy to put on. Whereas, in a heart failure patient or, cardiovascular patient with some other condition, it may be a different consideration. They're looking more at potentially monitoring their quality of life, their ability to, have max number of, movements per day or a max speed per day. In the Duchenne muscular dystrophy population, one of the things that was gathered after talking to patients and that led to actually a secondary endpoint in clinical trials is the 95th percentile stride velocity. And that was really, kind of brought upon by the patients saying that they felt their maximum speed loss was something that they could really, tell was an impact on their day-to-day living. And so consider, each population, whether this is for aging in general, this is for a healthy population to monitor their health, is this going to be used for patients with cardiovascular illnesses or patients with, a neuromuscular disorder? How can we make it accessible, both the interface on the technology as well as the wearing of the technology, so that it's not, something that adds burden to their day-to-day life. That's the last thing I think any of us want, is to make a condition that's already burdensome enough even more difficult. And so as a reminder, just very simple language can be very illuminating. So Marilyn had showed this yesterday as well, just asking some very basic how, why, what, who, when, how long, how bad can really be, important. And then all of this really, we would hope could lead to increased participation in clinical research, greater awareness of research, adherence to study procedures, a higher level of satisfaction with the overall experience, and potentially reduced attrition from clinical trials. And these also, I would say, are translatable into the clinical space as well, having increased number of visits, adherence to the visits, adherence to treatment, awareness of disease condition, satisfaction with their health care, and reducing loss to follow-up in general clinical practice. I wanted to bring up a little bit of an example that, maybe of a system that has maybe not fulfilled these roles, and the electronic health record system. When I first came to Boston to start my medical training, I think EHRs were just starting to become available. It's also around the same time that GPS really started becoming available. And you can see that maybe in the intervening years, probably the way that GPS has integrated into our day-to-day lives very seamlessly as a pretty accepted tool that really, if you live in Massachusetts and you drive in Boston, you can understand that it's very easy to get lost here on our roads. And GPS has certainly helped me get to where I'm going more accurately than I used to with a traditional map, as well as MapQuest, back, if some of you remember, when we had to use those kind of tools to get to where we were going. On the flip side, EHRs were coming around just the same time as GPS. And I think one of probably the greatest disappointments that caregivers and physicians and patients, I think, have found with EHRs is that it's really starting to detract from the interaction that's at the heart of a clinical encounter, which is you talking to a patient talking to you, and getting a sense of how are they doing at home? You know, as Brad was saying, you don't really walk down a hallway just to walk down a hallway, except in the clinic. And so in the doctor's office, you may be walking down the hallway just to walk down the hallway. And that's what the clinician is, you know, kind of gets to rate you in terms of, okay, how are the medications that you're taking? You know, how has it been since we made adjustments? If you're on a trial, they're trying to make a determination, well, you know, maybe this treatment is working for you, maybe this is not when it's experimental. And sometimes traditionally that's all we had. But we're really hoping that with the wearable space and with the connected technology space, that we can get a sense now of how somebody's actually doing at home. You know, before we really relied on the reported outcomes either from the caregiver or from the patient, but sometimes that can be limited by bias or recall errors, or you know, it just doesn't give you a complete sense when you're just talking in the office about what it actually means to see somebody with impaired mobility walking around their house or walking around you know, outside of the clinic environment. And we want to make sure we do this without necessarily distracting people from, you know, at the heart of this is the patient. You know, here the HR, this is a parody on Twitter where the HR is saying, you know, why are you talking to the patient, essentially? And I think that has been one of the complaints that has arisen in medicine, is really we've lost some of that patient-to-patient interaction that made people want to go into this field to help people in healthcare to begin with. So don't lose sight of that. Shamal had shared this as well as another example of that, where, you know, you have a patient here who says, I really worry that healthcare has become impersonal. And the doctor just tells them, well, no, that's okay. You know, just lie back and we'll scan the, you know, your barcode on your back here. And we really want to make sure that whatever, you know, solutions that you're coming up with, that you really consider the humanistic aspect of these problems and conditions that patients are facing. We don't want to make this more, you know, regimented and personal than, you know, some of what healthcare has become. And we're really looking to you guys to come up with these novel solutions during this hack. And we are looking very much forward to seeing what you come up with.
Brad, DiMe, that was fantastic. Thank you so much. You did a really nice job, I think, of outlining the sort of the promise of digital technologies in the service of health, being able to capture pieces of information that are more important to the patient themselves, to unburden them from having to come into the clinic, from sort of getting that granular detail that the sort of periodic snapshots that we get in the clinic can't quite probe. And Brad, some of the images you shared there, I think were really useful. Also, you know, we're not tech determinists here, right? Tech isn't always the right solution. So let's be thoughtful in how we apply it. Let's apply it to sort of really pressing challenges. And let's also think about overcoming some of the difficulties, whether that's a level of sort of tech or health literacy, whether that's access to those technologies, affordability, whether it's actually having insufficient sort of metadata around the clinical information flowing in to actually determine what it means. So appreciate you both setting the stage so nicely for everyone working on this track this weekend. We've still got a really good sort of crowd on the line here. So perhaps folks can use the chat function if you have particular questions, or raise your hand and I'll try and keep an eye out. Brad, DiMe, Shamal, and myself can hang on a little bit in case people have questions and in case we can provide any additional insights as you work on all of this. So a really terrific question for coming. What diseases are suited for studying with sensor data? I might, May, if I can, I might limit that really big but important question specifically to thinking about sort of digital measures of activity and different therapeutic areas where that might be most helpful, just for the purpose of our discussion today. Shamal, you haven't spoken just yet. Do you want to take a first cut at May's question? What diseases might be most sort of amenable to us learning from digital measures of activity?
Sure. Yeah. So the exciting thing about sort of studying mobility is that most conditions, almost any condition you can think of, either directly or indirectly, has an impact on mobility. There are certain conditions like neurological disorders, Parkinson's, multiple sclerosis, stroke. They have a very direct impact on mobility, and where improvement in mobility is a very primary focus in terms of the treatment. There are other conditions where it is sort of a byproduct or like a result of the dysfunction. So cardiovascular diseases could be an example. Again, I am an engineer by training. I've spent a lot of time working with folks like Shamal, clinicians and physical therapists. I don't know if Catherine is on the line, but they might also have really good insights in terms of like if you're looking at specific areas to target. But these are, I think mobility is really important, generally speaking. But if you focus on neurological disorders, for example, you can have a very direct impact on, especially if you want to bring that information back and design interventions that would help patients get better.
Shamal, do you want to, Shamal, thank you so much. And I think I might have heard a tiny human, which made me very happy. Shamal, do you want to add anything to Shamal's remarks? And also, I'm going to unmute Catherine in case she wants to follow you and Brad.
Yes, I absolutely agree with Shamal. I mean, there's a lot of disease conditions where activity is extremely important. I think neurological ones come to mind foremost because of the neural axis, being so important to control our movement. Anything from spinal cord to the brain. How do we balance? How do we walk? How do we move? Movement disorders, neuromuscular diseases, spinal cord injury, brain injury. All those things have a direct impact upon the muscles of which we are moving. So definitely neurological diseases, and remember that that's a spectrum of everything from children all the way up to adults. So kind of that population, you'll have to think of who are you going to target for that. And then beyond neurological conditions, I think Shamal mentioned a few, arthritides and joint mobility issues. Injury, any kind of injury can affect mobility. Other disease conditions that come to mind include our oncological population. If you think about how we treat cancer patients, a lot of times how you get into a clinical trial really depends on your functional ability. Do they think that you're going to tolerate chemotherapy? The clinician is just basically rating how many times a day they think that you can, that you're walking, and how mobile are you in order to be able to tolerate therapy. And we know that in certain cancer conditions, both the treatment as well as the disease itself can lead to muscle wasting, diseases like cachexia, which can also impact somebody's quality of life and functional mobility. So it really is, if you name a disease, we could probably tell you some impact that disease may have on somebody's mobility. But those I think are the kind of first and foremost examples that really come to mind.
Fantastic. Thank you, Shamal. Thank you, Shamal. May, hopefully those are good answers to your questions. And if not, head on over to our Track and Slack. We'll have lots of mentors. I actually tried to unmute one of our volunteers, a terrific physical therapist and expert, Catherine. She, I can't figure out how to unmute her, but she will be on the
unmuted,
Slack.
I think.
Oh, terrific. There you are. Yeah, hey, Catherine.
Sorry about that. I mean, it's just Shamal and Shamal have been, providing such an amazing overview of, the scope of application of monitoring with wearable sensors. That I'm not sure what I can add to that. As a physical therapist, it's of course very important to me to have an idea of what my patients are doing at home and what difficulties they are encountering. So I really like this idea, of this concept and capability of being able to monitor my patient beyond the clinic, where actually, my intervention are useful, and collect more data points, being able to follow them more closely instead of, evaluating them at, the beginning of my intervention and then at the end. And then if I figure out that they didn't make, any meaningful progress at the end, I don't have any more therapy sessions. So I need to be able to find out that what I'm doing is actually having an impact. And so that's the beauty of wearable sensors or other technologies, because we don't always have the time in the clinic to perform detailed assessment when we see patients.
Fantastic, Catherine. I really love the idea of sort of highlighting how important it is to get sort of high quality real-time information to inform those sort of clinical decisions, and for you sort of to inform you of whether sort of how you're working with your patients is working, or if there are additional things you need to pull in. May, hopefully that answered your question. I'm going to move on and take another one from Prayag. And Brad, I'm going to ask you to take a first cut at this one, if you wouldn't mind. So if step count being correlated to health status, but it's not the real ground truth variable, is there a more complex or direct measurement that's a closer approximation of health status and does not have to be cumulatively measured across the day? And Brad, maybe if you want to take a first stab at that, and then Shamal jump in.
That's a good question. I think maybe to follow up on, I think because of the complexities, right, there's, yeah, maybe just quickly to follow up on the last point, I think one of my supervisors is a geriatrician, and he's been a geriatrician for 35 years. And I think he kind of makes up his diagnosis within the first few seconds of seeing the person walk in to his clinic. And so I think to Catherine's previous point, to provide more information about the effects of kind of the management. So if Parkinson's is the diagnosis, we might be able to use connected technologies to, for example, monitor the effectiveness of a medication or a specific kind of intervention. So I think that's one really important point. And I hesitate to answer this next one because I think it really depends on the specific disease, syndrome, or condition. I don't know, Shamal, do you have any other follow-up thoughts on that?
Yeah, I mean, I spent a lot of time thinking about what digital measures you would want to extract or derive for a particular population. And you're right, Brad. What you want to measure really depends on the population and the type of impairments that are present in that population. So an example would be, one of the examples that you showed was that the gait speed might be the same between two older adults, but the variability is an indicator of a higher variability is an indicator of potential, dementia, right, cognitive issues. The same thing could be said about, for example, if you have stroke and you have unilateral impairment, then asymmetry might be something that you would be interested in. So are your left steps different than your right steps, right? Are you taking longer steps on the left side and shorter steps on the right? And once you understand what type of impairment is present in a population, you can really design these digital measures that can tell you whether there is an improvement. Is there something you can do about helping patients with those types of impairments as well? And in recent times, there has been a lot of work on also using more abstract techniques, machine learning, AI type of techniques, to build these more sophisticated nonlinear approaches that embed a lot of information into a single single measure. That those are also ideas that you can explore. But I think the thing that I think you should always keep in mind is the population and the patients who you are focusing on, and kind of work backwards from there.
And just a quick follow-up. I see a follow-up saying to scope it down, are there any for fall risk or frailty? In my mind, most falls occur when people are standing and walking and become distracted or involved in a secondary kind of cognitive task. So from that standpoint, I think the actual movement outcome itself is not as important, but kind of providing multimodal kind of information that provides not only the movement, but the kind of task will be really, really important.
Brad, I'm really glad that you picked up that question. I want to be respectful of the schedule of our sort of Grand Hack colleagues. So I know there are a few questions still pending. Let's plan to move those over to the Slack. We can take those there on our channel. We're happy to do that. We also have a lot of mentors from a variety of different backgrounds, from sort of technical experts and patients, clinical experts. We even have a VC joining tomorrow morning to answer any questions you might have on sort of funding. One of the last sort of quick comments that I wanted to make, one of the questions I saw was about sort of cumulative and continuous measures. I think while that is sort of a promise of digital, a few high quality sort of data captured through the day, I imagine something like intentional bouts of walking. I don't think you have to limit yourself to true continuous measures 24/7. I think there's a lot you can extract, and I would encourage everyone to sort of be thoughtful about the signals you're looking for, and actually, do you really want to burden the participant with continuous measure? There's also issues around sort of privacy and things like that they may actually prefer to be sort of surveilled a little bit less frequently. So lots of opportunity here. We're really excited to have you all engaged in using these digital clinical measures of activity to improve lives. Let's take these questions over to the Slack. Jumei, Brad, thank you for tremendous remarks. Same too for Shamal and Catherine, and we look forward to working with you throughout the rest of the weekend. Thanks, everyone.
Thanks so much, everyone.